Well, welcome to another episode of Inside Human Medicine. I'm your host, Dr. Henri Ford, the Dean and Chief Academic Officer of the University of Miami Miller School of Medicine. Today, we welcome to the studio Dr. Macarena de la Fuente. She's an Associate Professor of Neurology and the Chief of the Neuro-oncology Division in the Department of Neurology at the Miller School of Medicine and U Health. She's also the Director of the Neuro-oncology Fellowship Program. Dr. de la Fuente, now I should say Dr. Macarena de la Fuente, and she says Macarena just like the dance. She is an internationally renowned expert in the management of brain tumors. Her research interest focuses on a particular type of brain tumor that has a mutation in the isocitrate dehydrogenase gene, and we'll learn all about that. Specifically, she's interested in exploring effective yet less toxic treatments for these particular tumors that are quite lethal in nature. But before we get into the substance of this podcast, please tell us a little bit about your background, your journey from Argentina to becoming the chief of the Neuro-oncology Division at the Sylvester Comprehensive Cancer Center of the University of Miami.
So good morning, Leopold. It's really my pleasure to be here today. And really have, beautiful memories from my childhood in Argentina. And my parents believed that education was the best gift that a parent can give to a child. So by the time that I was 6 years old, I have a full schedule. So I was going to school, and then in the late afternoon took like piano classes and languages classes and all of that. And over the weekends, I like to, ride my horse and do things like in the countryside. And, from there, I really developed this, I really like, math and science in the school. And that, brought me to this, journey in a way.
Got it. So, okay, here you go, actually multi-talented youngster growing up in Argentina, and there were also so different, diverse interests in math and science. And why did you choose to pursue medicine? What inspired you?
So, my dad had a spinal cord injury when he was like a young adult, even way before I was born. And I was always very interested in understand why, he was able to move his arm but couldn't move his legs, and why if I touch him here or there, he could feel or he couldn't feel.
So what were his deficits?
So he has spinal cord injury. Right. So he has a spinal cord lesion.
Right. And what you said, he could move parts of his leg, or one side was affected versus another?
No, really, as having a spinal cord injury, he had a paraparesis, so he couldn't move his leg, but was able to, have full functionality of the upper part of his body.
And so that
brought me in really trying to understand what happened to him. And of course, as a little kid, probably try to, cure your dad. You will fix that, in a way. And that brought me to, I think medicine and neurology eventually.
Great. So I can understand how that inspired you to try to understand why this spinal cord injury manifested itself the way it did. But how did you get into brain tumors? And you went to medical school in Argentina?
Yes. Yeah. So I went to medical school in Argentina, and I did my neurology residency in Argentina. So during residency, one of my first patients, had a primary CNS lymphoma. And the patient was really clinically doing very...
And for those uninitiated, that the central nervous system.
Yes, sorry about that. Yes. So it's a primary central nervous system lymphoma that is a very rare, tumor. So the patient was not doing well, doing really like bad clinically. He was admitted to neuro ICU. Was a newly diagnosed tumor, so the patient started his treatment with methotrexate-based chemotherapy. And the patient improved so much. Was really amazing for me as a new doctor, seeing how much he improved clinically and how his MRI was improving as he was getting this treatment. So I start reading, and searching about, researching about this disease, and I found that many of the papers were written by the same doctor, Lisa De Angelis. Mm-hmm. So she became a little bit of my idol in a way, So I started doing research on primary brain tumors. I, submit a retrospective review on this type of tumors to the American Academy of Neurology and present that as a poster. And I was so lucky that she showed up, at the poster session. So for me, it was for my daughter meeting Taylor Swift. So I'm from, from there. So, okay, this is what I really love to do. And then, from there, I finished my residency. I took all the steps, to be able to practice in the U.S. and went to fellowship at, Sloan Kettering under her mentorship and so on.
So that was fortuitous, and you were curious, you did the research, you presented a poster, and you happened to meet your idol, and then you end up doing your fellowship with her. What a fabulous story. And now you are this world-renowned neuro-oncologist. So tell me about the field. Tell me about this business. What is neuro-oncology and brain tumors in particular? Tell us a little bit about the most common types and why in particular you're focusing on gliomas.
So gliomas are the most common, primary malignant brain tumors. And they're rare tumors when you compare to breast cancer or lung cancer, of course.
How commonly do you get?
So we see it all the time, of course, but these tumors may occur in 90,000 people per year. But the problems with these tumors are incurable, and they're very difficult to treat, and especially the IDH mutant gliomas or the low-grade gliomas occur in patients.
And the IDH, that's the isocitrate dehydrogenase gene. What does that do? I mean, why is that so important? Mm-hmm.
So that's basically an enzyme, and it's part of this, Krebs cycle that we all study in medical school. But
you mean those things we study in med school actually matter?
I think so. This one is matter. This one is very, very, very important.
This is for my medical students who are listening.
Go back to biochemistry. I of course did that the first time that I encounter IDH again as a doctor now. But really, the presence of this mutation in gliomas actually is a good prognostic factor, So patients with IDH mutant gliomas do better than patients with glioblastomas or wild-type gliomas.
Why?
But what happened is that, even the tumors behave well and patient has a better survival. As I say, these tumors present in younger patients. So of course, we have the issue of the mortality, but we also have the issue of the morbidity of the limited treatments that we have for these populations. And that means that, the standard treatment for these tumors is, resection, so removing the tumor with surgery. And after that, the majority of these patients get radiation in combination or followed by some type of chemotherapy. And this treatment long-term can cause a variety of side effects, from cognitive issues, and other sort of toxicities, and then really affect, the quality of life, our financial burden for the patients. There are young patients that are probably in the peak of productivity at work. They have young families. So really, the tumor and the treatment really affect as a whole, the human being.
So gliomas are incurable. The isocitrate dehydrogenase gene mutation is protective to some extent, or at least it confers a better prognosis. We're going to get back to how. And the treatment, even though the disease is incurable, so it's almost the palliative treatment ends up being quite toxic. So your goal is to not only find a really effective treatment, but also whatever we do to make sure it's less toxic. Does that encapsulate everything for the layperson?
Yes.
Okay.
It does.
Great. All right. So, and I understand the morbidity and the disease burden being not just limited to the patient, but also to the family. How are you targeting this particular mutation to improve the prognosis, or at least decrease the morbidity for the patient, and also prolong life?
So I started working on, IDH gliomas and IDH inhibitors, so drugs that target this alteration when I was a fellow, and over this, over a decade of work, others and I has been going from, doing the first in-human trial with these drugs, phase 1, and, phase 3 trials that we recently published. And we have done, trials, like international trials with many collaborators, and really trying to identify when is the best time in the course of the disease to introduce this drug, and how toxic or not these drugs are, and how effective or not these drugs are.
And why does targeting this particular enzyme influence the prognosis? I mean, what is it that this IDH mutation lead to? What does it lead to that you can target to improve the prognosis?
So IDH mutations really change, the cell, in a variety, of aspect that, and what we are trying to do is target that alteration. So the cells turn in a way into a more normal cell. That's what we are trying to do with this.
So they're more responsive to chemotherapy then?
No, I will say more to differentiate to a more normal cell, and stop or lose the effect of the mutant enzyme. When the enzyme is mutant, generate a product like a non-com metabolite is called, and that is the effector of all the changes in the cell. So we are trying to reverse that in a way with the inhibitors.
Got it. And while it may influence prognosis, it doesn't necessarily prevent recurrence. Is that?
That's true. Unfortunately, even IDH mutations are a favorable prognosis factor in these tumors. Eventually, these tumors progress, progress in grade, and are eventually fatal tumors. So we really need better treatments.
So to tell us about some of the intervention that you have been made based on your research for decades now to try to improve the outcome for this patient.
So we have done a variety of clinical trials, some that we were leading and some that, my mentors and others has been leading. And we are very, excited about the results, the large phase 3 trials that, were able to publish last year demonstrate that, when we treat the patient with these drugs after surgery, but before radiation and chemotherapy, so far we have demonstrated that we can, prolong the progression-free survival and prolong the time when the patient need a new therapy. And of course, the data is evolving, and we are hopeful that will impact, survival, but we just need to see how the data mature in that aspect. So I think, there a room, there a space for these drugs in the treatment of these tumors, and we are hopefully expecting that these drugs will be approved within this year to start treating, the tumors.
Your work is really critical because as a surgeon, I know that when we remove a tumor, we do have we call it a complete resection, and usually that's enough. In the case of the brain tumor, you can have a complete excision and you get an MRI and everything is gone, and you even give radiation therapy and it still comes back.
Why?
What is wrong with this tumor? What's wrong with this picture?
So what happened is these tumors, are infiltrating tumors. So basically, like the tumor cells infiltrates the normal tissue. So we don't have borders, we don't have edges for these tumors. So that's why surgery is never a cure for this tumor. Even it is by far the best first step in the treatment of these tumors, is never enough to cure the tumors. And that's why they progress. And then, especially when the tumors turn into a more aggressive tumor, they are very heterogeneous, not only from one tumor to another, but also within the same tumor. So it's very difficult to target, then the tumor with one single drug.
So you're telling the audience a lot of important things. That not only do they infiltrate, but it says that after they infiltrate, they have a more aggressive phenotype. They can be even more lethal than the original tumor that was removed. So we need to have. So that means you have to have very powerful drugs to go after them, which would make it more toxic. How do we balance all that? Yet you're trying to come up with less toxic drugs to minimize morbidity. How do you still kill those infiltrators and still minimize the toxicity?
That's a very good question, huh? So we are trying to do that. This is why I think it's so important to understand when is the best time to introduce the drug and learn from the tissue samples that we obtain, learn what are the mechanisms of resistance to these drugs and what combination of drugs we can do early on to try to prevent, to try to delay that progression and try to prevent that, evolution of the tumor.
Fascinating. So are you suggesting that the best approach could be, could be neoadjuvant therapy, meaning giving medication before you go after the tumor surgically or giving radiation therapy and so on. So I'm just curious, or is it that with the tumor impacting the brain, you just have to quickly intervene to minimize some of the effects of having this tumor putting pressure on your brain cells?
Yeah. So, that's I think is a good question, and we really don't know that. But we know for sure that the earlier we can treat the tumors and can intervene, the better. We have some clinical trials, designed where we give the patient some drug and then we remove the tumor and then continue the treatment. And that helps us, especially in this particular, challenging disease, when it is not only important to be able to target that mutation, but also be sure that the drugs get into the brain and we are seeing basically the biological effect of the drugs in those tumor cells. So that's another piece of why it's so complicated to treat these tumors.
Good. So what have you found thus far that seems to be most promising in your clinical trials?
So we can turn a little bit, the topic. I think we have been discussing about, IDH mutant tumors and how to target those with IDH inhibitors. And I think that will be really, a practice change therapy that will hopefully approve this year. But we are also working on other, type of gliomas that has different alterations. And we have been working, for example, in tumors that has this alteration that is called BRAF alteration that is very...
What does that stand for?
Yeah, it's complicated to even say, but it's an alteration that is very common, in melanoma, in some thyroid cancer, and in many other diseases, and is an alteration that we have been studying and targeting, and there are drugs that has been approved in the recurrent setting for this type of tumors, including brain tumors. But in brain tumors, about 30% of the patients ended up discontinue those drugs because of toxicities. So we have been working on a new BRAF inhibitor, with a new mechanism of action, and we recently presented that data. And we demonstrate that not only the drug has a better toxicity profile than the standard drugs with less rash and less fevers and, less even secondary malignancy that can happen with this tumor, but also we are seeing a better response rate, over 50% of the tumors, of the brain tumors, reducing in size. So now we move along and we are doing the phase 2 study to confirm those findings from the phase 1 study. And we are also working with many colleagues around the country to bring these drugs to the upfront setting, trying to, again, treat the tumors with these drugs when they are when they're initially identified.
So, this is the simplistic mind of a pediatric surgeon. The tumor infiltrates things. You want to, it's infiltrative in nature. You want to get to it early. But it could be, the mutation could be in the BRAF or it could be IDH1. So how would you decide a priori which treatment you're going to enroll the patient in if you want to get to it early?
Yeah, so what we do, this is why I say is key in this case, the role of the neurosurgeon. And when we can resect these tumors, we resect the tumors. When we cannot resect the tumors, we always go for a biopsy. So we get the tissue, we analyze the tissue in the lab. We get that molecular profile back just in, 10 days or so. So by the time that the patient recovers from the surgery, we have the data that we need in order to take the best decision, in terms of treatment for the patient.
Got it. So you always get at least a biopsy
yes,
to work.
Yes, of course. And yes, no question.
And so that allows you to choose the drug regimen you think is going to be most effective. So tell us how long do you treat with a particular regimen, and do you monitor toxicity response? What are the priorities? What is the hierarchical order here?
So yes, we do basically all of that. When the patients are, the standard of care for these patients, as we say, is surgery followed by radiation and chemotherapy. And in general, the patients do, chemotherapy for like 6 to 12 months. But when the patients are on these inhibitors, they can be on those drugs for many years. Actually, I have patients that from the initial phase 1 study that has been on these IDH inhibitors for 7-8 years, and we
7-8 years. I thought this was lethal. So you have survivors. So this is exciting.
It's very
promising.
It is very exciting, and of course, we monitor the patients for toxicities, mainly through the lab results, and we monitoring the MRIs to see if we are seeing a response. Of course, to be sure the tumor is not growing on the drugs and so on. So the patients get MRIs every 2 months, every 3 months, and we see them every month when they are on treatment.
So there is hope.
Of course,
it's fatal, but what you're saying is that the interventions are promising, and then the FDA is considering approving the IDH1 therapy, targeted therapy.
Yes.
That's fantastic. And then BRAF, where do we think we're going?
So basically, BRAF inhibitors are approved for recurrent disease, and we are for recurrent disease, and we are working on trials to see if we can treat these patients in the newly diagnosed setting.
It's fantastic, and I can't wait to have you back to tell us about the progress that you're making. So you have really opened, the floodgates of hope for all those patients who are affected by this devastating disease. Let's talk a little bit about you. Now you're from that young person who used to idolize Dr. DeAngelis, you've become really a leader in the field, and you were recently elected to a leadership position in the Society of Neuro-Oncologists. Tell us a little bit about that and what's next for you.
So I have been involved with the Society for Neuro-Oncology for many years now, and I was recently elected to the board of directors of the society. So I'm very proud of that, and I hope that I will be able to contribute to the society mission. But before that, I have a different role in the society, and I was one of the co-chairs of the Women and Diversity Committee. And as part of that role, one of the tasks for our term was to help the society become more diverse. And diverse in every single aspect that you can imagine, not only to have more females, within the leadership roles as moderators, in the annual meeting, but be sure there are, for example, institutions are well represented in the society. And we have been working, with a consultant and leadership to really transform the society and that aspect. And we are really thrilled, with the result of those intervention. And also as a result of that task, we recently launched Society for Neuro-Oncology Future Leadership, program. So a way to help young physicians to develop those leadership skills and, know about the society, and for the society, current leaders to know young people, to be able to give opportunities to, the next generation of scientists and physicians. So
you being a sponsor, a mentor and sponsor to that organization, that's fantastic. And you also recently assumed some important leadership role in Sylvester as a co-director of the Brain Institute led by Dr. Averoni.
Yes, exactly. So, May is Brain Tumor Awareness Month. And we are thrilled to announce, the launch of our Sylvester Brain Tumor Institute. And Dr. Yavaron, I know, was with you a few months ago in this podcast. So he will be the director, and I will be one of co-directors with Dr. Comotor and La Sorella. And really, the goal of the Brain Tumor Institute is to be able to enhance and promote and be able to accelerate Sylvester research in terms of brain tumors and be able to translate the discoveries from the labs to better treatments for the patient and really train the next generation of physicians and scientists.
And hopefully we can find that elusive cure that you already tantalizingly got us excited about with the 7-8 year survivor with IDF mutation. So, Dr. Macarena de la Fuente, what a phenomenal pleasure it has been to talk to you for the past half hour. Your work is very important, very impactful, but more importantly, you're a role model and inspiration for many of our young rising stars, women and men in medical schools. So I hope you will continue to inspire and sponsor them. So thank you so very much for spending the time with us, and we look forward to having you back on the program, hopefully soon, with even better news for our patients affected by gliomas. So thanks again.
Thank you so much, Tim, for the opportunity.
And this has been another episode of Inside Humanity Medicine with our superstar guest, Dr. Macarena de la Fuente. Join us again next time for the next episode of Inside Humanity Medicine podcast. Henry Ford, till next time.